Our next speaker, V. Kim Kutsch, completed his DMD at the University of Oregon School of Dentistry in 1979. He is an inventor holding numerous patents in dentistry, product consultant, internationally recognized speaker, and is past president of the Academy of Laser Dentistry and the World Congress of Minimally Invasive Dentistry. He has also served on the board of directors for the World Clinical Laser and Imaging Institute and the American Academy of Cosmetic Dentistry. Dr. Kutsch has published dozens of articles and abstracts on minimally invasive dentistry, caries assessment, digital radiography, and other technologies in both dental and medical journals, and contributed to several textbooks. He maintains a private practice in Albany, Oregon. His topic today is dental caries, the usual suspects. Please welcome Dr. Kutsch.
Well, I'd like to thank the committee and the Academy for inviting me to give you this presentation today on dental caries. Anytime I have an audience and I get to talk about dental caries, I'm having a great day. My presentation title today is Dental Caries, the Usual Suspects. As we've learned more about dental caries over the last few years, in terms of our research, this disease continues to become more and more complex, and it's the #1 disease in the United States and all age brackets because it's such a difficult disease to treat and control and manage. A better title for this presentation today might actually be Dental Caries, Not the Usual Suspects. When I was in dental school 35 years ago, I was taught that dental caries was a function of mutans streptococci and lactobacillus. But as we've continued to make progress in our scientific research, we understand that it's a lot more than just that. There's something missing in the way that we approach and treat this disease beyond just looking at those two bacteria. So when we look at our scientific progress, we begin with the intuitive model of medicine and an intuition, and we still use this every day in our practice. I look at you, I trust my gut, my clinical experience, and I make a decision on what I think is going on and what I think might help you. As we progress, we come to the point with the empirical model of medicine where we have systematic reviews of random controlled trials, and now I can express what I'm doing in terms of probabilistic terms. I've recognized this symptom. Based on our research, I know that you have an 80% confidence that you've got this disease, and if I employ this remedy, I know probabilistically that you're going to get this kind of result. And what we're really trying to move toward is precision medicine. And precision medicine is a model of care where we can identify exactly what's causing your disease. We can test for it, we can measure it, and we can monitor it as we treat it. So CAMBRA, or Caries Management by Risk Assessment, really represents a step forward for us looking at trying to create this precision medicine model in treating dental caries. So what is dental caries? Today I define dental caries as a transmissible biofilm dysfunction of the teeth marked by prolonged periods of low pH that results in net mineral loss. So in simple terms, dental caries is a pH-specific disease. And it's a biofilm disease. Biofilms are what we are studying today. And if we look at the biofilm model of dental caries, at present we know that there are multiple pathogens involved. We know that there are potentially systemic effects from this disease, and we know that there are hereditary factors. And we're continuing to add in our evidence base all of those different factors. Now, I understand that Bill Costerton has given a presentation to this organization on biofilms, so you already have a base understanding of biofilms. And Bill Costerton has certainly been a resource to me as I've been on this journey of my own in the last 10 or 12 years. But you understand how differently bacteria behave when they're planktonic versus when they're a part of an integral community. So if we look at our most current scientific literature around this biofilm model, this is from the Journal of Caries Research, January of this year. Diana Wolf and her team at Heidelberg University took 26 high caries risk patients and 28 caries-free patients, looked at a panel of 43 different bacteria, and found the only bacteria that associated with dental caries was Propionibacteria acidifaciens. So I was pretty excited when I read this because in 2010, David Baton added bifidobacteria, and Ann Tanner and her group at Forsyth had a great year in 2011. They added Scardovia wigsii and Slackie exigua, and then 2012 was kind of a slow year for us. And so we got an additional pathogen to add to our group of suspects here just in January. Nakano's group in Japan, as early as 2005, began reporting taking samples cardiac plaque samples of patients undergoing surgery in the hospital, and they asked the question, we know that there's going to be periodontal pathogens here, we've seen the research, but what other oral bacteria are present? And when they did the research, the bacteria that was present, when it was present in the mouth, it was found 78% of the time in the coronary plaque specimen, turned out to be our friend Strep mutans. Now, we also know that Strep mutans has a gene that actually allows it to directly invade endothelial cells. That's the CNM gene. So I'm not proposing to you that it causes systemic effects, but we certainly know that it irritates, aggravates other systemic conditions like ulcerative colitis. The conclusion they made in the series of studies was that Strep mutans is, in fact, they believe, the etiologic agent for most bacterial endocarditis. And then this paper was published in the Journal of Dental Research this year, Schaefer and Feingold, and they published 3 papers last year looking at the inheritable traits for dental caries. And there have been a number of papers published in the last 12 months looking at dental caries as a genetic disease. And I found this paper most interesting. It was a study of 920 adults. It was a genome-wide association study. They looked at 518,000 gene sites. And they found 11 strong associations between genes and dental caries. The strongest of those was lysyl 2, and it's a bacteriolytic enzyme found in the saliva. It's a protective enzyme. And one of the other things that they reported that I found very interesting was that they also identified specifically in their data there were 5 distinct geographic patterns of decay in the mouth. And they termed those different phenotypes of dental caries. And for the first time, somebody's beginning to identify dental caries as not just a cavity is a cavity, but depending upon where it's in the mouth, it may be caused by different factors or risk factors. And this lysyl 2 turned out to be related mostly to a bacterial or a dental caries pattern that occurred in the mandibular incisors, only in the mandibular incisors. So as I'm reading this paper, I think it's very interesting, but clinically, I'm not sure I've ever seen a patient that had only cavities in their mandibular incisors. Typically, those are the last men standing in this disease. And then a week later, literally, a new patient was referred to me by a pediatric dentist locally, and this 14-year-old girl that you see on the screen, they've repeatedly restored these mandibular incisors. It's the only decay she's ever had. And so I now have a case study of one in my own clinical experience, so I find this very interesting. And Takahashi and Nevad, over the last 5 or 6 years, have continued to paint the landscape for us in terms of how we look at dental caries. And this paper is just out. This is the current issue of the Caries Research Journal. It's the March-April issue of 2013. And I find this paper really interesting, and I want to present it to you today because they present kind of a novel thought. Instead of worrying about what bacteria are present in the biofilm behaves as a single organism. Biofilms behave as a single organism, a superorganism, if you would. And so instead of worrying about which bacteria are there, we should look at the entire genome, the entire set of genes that are present, because our next generation sequencing technology allows us to do that. So it's not really important which bacteria are there, but what set of genes, because it's the genes that are activated that create the proteins, that create the metabolism, that create the metabolic output. And we can measure each of those now. And we're working toward that. And so it gives us an opportunity then to start thinking about not who is present in the biofilm, but what is the biofilm? What is the metabolic output of the biofilm? So Canberra, Caries Managed by Risk Assessment, represents a quantum leap forward in kind of our approach to treating dental caries. I would have to tell you that I think Bob Barkley put us on the map in terms of prevention back in the 1970s, and this paper by Max Anderson in 1993 really reset my GPS, and I think for a lot of people in the profession, Max, thank you, Max, by the way, this was life-changing for me because it took me out of the box that I'd been placed in dental school and opened my mind to thinking that we could treat this disease like a disease. When we look at caries risk assessment, the best research that we've got comes from John Featherstone and his team at UCSF. In the CDA journal in October of 2011, they reported a 6-year retrospective study on 12,954 patients in the dental school. And they identified disease indicators and risk factors, and they gave us the odds ratios of each of those over that period of time. And it validated the concept that caries risk assessment is a valuable tool for assessing this disease. So in my private practice, I don't really use terms like propionic bacteria acidophacans because that's not really going to be meaningful for patients. Now, Bob Barkley in the 70s used an analogy of the house is on fire. Do we call the fire department or do we call the carpenters? And I've started using, years ago, an analogy for my patients that, this is a simple process. We're going to assess this. And I tell them getting a cavity is a lot like getting a nail in your tire. We use a caries risk assessment form. This is one I developed for my private practice based on John Featherstone's research. We look at disease indicators, risk factors, and then I also have been measuring for 9 years the ATP bioluminescence, which really is a function of the activity or functioning of the biofilm. And then we make our assessment, we make a diagnosis. And the problem for these patients isn't that they have a nail in their tire. The real problem they have is that they've got nails in their driveway. And so patients understand that. So these are the risk factors that are driving this disease. And the ADA Council on Scientific Affairs gave us the definition and the outline for risk categories for children and adults back in 2006. These are available. And then the third step in this process is to prescribe our therapy. Not only do I need to repair the tire, but I need to find out why you have nails in your driveway, how many there are, and help you get rid of those. Because if I can get the nails out of your driveway, I can help you stop getting cavities. So when we look at trying to create balance then, prescribing therapy to treat this like a disease, again, probably the best research I could cite to you is John Featherstone's work again at UCSF. This was in the Caries Research Journal in March of last year. They looked at 231 adults. They tracked them over a 2-year period of time. They measured them for mutans streptococci, lactobacillus, and fluoride levels. And they also treated them with chlorhexidine, fluoride rinse, and 1,100 part per million toothpaste. Now, what they found was they greatly reduced the mutans streptococci levels. There was no effect on the lactobacillus or the fluoride levels, which I wouldn't expect with chlorhexidine in the first place. But on secondary analysis, they also reduced the DMFT scores of the test group. So that what they did, while it wasn't a home run study, they did show us that it's possible to alter the balance of these risk factors on patients by using some kind of prescriptive therapy. So when I look at then, what are our strategies going to be that we're going to prescribe? Well, I start with 3 different ideas. The first is reparative. We need to repair what the damage has been done by this disease in the mouth. The first step in that would be remineralization. And the best scientific evidence we have yet today for remineralization is fluoride, and fluoride in the form of fluoride varnish. And for the high-risk patient, that would be every 3 months. Now, granted, if we are honest about our evidence base, we don't have a lot of great scientific evidence on fluoride in adults. We extrapolate that data from the evidence that we have on children. And then we still need to restore the teeth. And if I have a high-risk caries patient, typically I'm going to stage that treatment, and I may use an intermediate restorative material while I'm working on biofilm modification like glass ionomer. Then we also have therapeutic strategies, and under there we have antimicrobial products, we have metabolic strategies, and we have pH strategies. I kind of included probiotics on this list. I think we still have quite a bit of work to do on probiotics. I think they're interesting and they offer some promise to us. Under antimicrobial products, you basically have sodium hypochlorite, which I favor, chlorhexidine, and also povidone iodine. Metabolic products are typically xylitol, and then pH strategies to kind of replace the benefit from the saliva if they're missing saliva. Now, we also have behavioral strategies, and under that we have modifiable strategies and potentially modifiable, and that would include diet and home care. And then we also have non-modifiable. It may be medication-induced xerostomia. It might be part of the aging process. It may be an intellectual disability. So I started this presentation today with the usual suspects and said it's really not the usual suspects. In fact, today my usual suspects would be bacteria. If they have a bacterial or biofilm dysfunction, they typically have too much bacteria or they have the bacteria behaving badly. If it's a dietary issue, typically it's a function of they either have too much sugar in their diet or they're eating too frequently. If it's a salivary issue, typically it's that they don't have enough saliva. It's xerostomia, and that's a real problem for us in a lot of our senior patients now, even in some of our children. Or they may have poor buffering capacity, and I added for the first time this year genetics, because I believe really this is a new suspect for us. But at the end of the day, spoiler alert here, the culprit is Kaiser Sose, and it's really all about the pH. So I present these two patients to you today to consider. They're both females, mid-30s. They're both high risk for dental caries. They're both new patients in my practice. These are the first photos that I took of these patients. I think you can appreciate that what's causing the disease on the patient on the left is substantially different than what's causing the disease on the patient on the right. Now, in the intuitive medicine model, we would use drill and fill, we would restore the teeth, we tell the patient to brush and floss. As we move forward to the empirical model of treating this disease, we would then assign both these patients therapy with, say, the gold standard had been chlorhexidine and fluoride rinse. Now, chlorhexidine is probably going to help the patient on the left. She has too much biofilm. But the patient on the right is taking some medications, and she also has a hereditary risk for Sjogren's syndrome. She's xerostomic. She doesn't have too much biofilm. She doesn't have a biofilm issue. She has a saliva issue and a pH imbalance in her mouth. So in the precision medicine model then, what we're looking at is we need to figure out exactly what's driving that disease for each of these patients so that we can target our therapy rather than giving everybody a one-size-fits-all. And that's really where I believe some of our scientific method breaks down, because this is such a complex disease that unless we're able to identify specifically for a patient and treat them individually, looking at population studies don't give us the kind of results that we're looking for. But we would then employ some type of targeted therapy. For the patient on the left, we're looking at modifying the biofilm, dietary. She had a dietary behavior problem also. And the patient on the right, we need to support the pH balance in her mouth. So this is not rocket science. At the end of the day, the suspects drive your treatment strategies. If they have a bacterial issue, we're going to use antimicrobial agents. We're going to talk about their behavioral issues, maybe around brushing and flossing and home care. If they have a dietary issue, we're going to talk to them about limiting their sweets or limiting their snacking. If they've got a hydration issue or a saliva issue, we want to be able to help them hydrate and balance their mouth. So I'm going to leave you with this final thought. These patients, high caries risk patients, come with high restorative need. The price of that is high restorative risk. And so you can't drill this disease away. We know that. And your restorative success on these patients at the end of the day isn't going to depend upon which resin system you use. It's not going to depend on which composite or which implant or porcelain system that we use. At the end of the day, our restorative success on these patients is going to depend upon how we manage the biology. So I'll leave you with that thought. You've all inspired me this weekend. I thank you for that. I hope that my presentation inspires you to think differently about your caries patients. Thank you.